So this is a topic that's very near and dear to my heart. And basically these concepts are very new, but in a way very old. So financial toxicity is the idea of basically the out-of-pocket costs and the lost productivity that patients pay because of their cancer as they're living with cancer. This can include obviously, medication copays. This can include parking costs at the hospital. This can include the opportunity cost of not being able to work. A lot of patients, for example, after transplant don't return to work, and that's financial toxicity right there. A newer concept that I'm really trying to help push forward is the idea of time toxicity. The idea that a lot of things we're doing in myeloma are not necessarily high yield. They're not necessarily helping people live longer or live better, but they do mean more time in clinic. And again, all the things that come with not being able to spend time at home come here. And so basically we interviewed 250 patients with myeloma who had undergone transplant at our center to say, hey, what is your experience with financial toxicity and with time toxicity? And we found a couple of interesting things. So financial toxicity we found was actually pretty stable. Both patients who are on frontline therapy versus observation after CAR T, for example, versus active therapy, about 25-30% of them reported financial toxicity in some way or form. The time toxicity part is what I was really blown away by. So patients on active treatment, 86% of them reported time toxicity. So to be clear, we define time toxicity. We actually talked to patients and said, how would you define it? And we based the definition of being at least spending at least once a week dealing with your myeloma in some way or form, either for clinic, blood work, infusions, phone calls with pharmacy or insurance and so forth, or having to do that once a month in person while also living very far away, 4 hours away. And basically we found that, again, for patients on active therapy for relapsed myeloma, 86% of them had time toxicity, which makes sense. Patients are very brave and they'll do anything to kind of move the myeloma back into remission. But even for patients on maintenance, on LEN maintenance, 30% of them reported time toxicity. So patients who really should be living the life as best they can because they're in remission, they're on maintenance therapy, a lot of them are still dealing with their myeloma once a week or once a month in person with very long travel distances. And so, we have limitations. There's a survey of patients. We didn't ask them where the time toxicity was stemming from. I have my theories, and this is kind of where our prospective research will come from. There's a lot of stuff that we do in myeloma that is low yield, as I alluded to earlier. I think examples of that, for example, would be, how often do we check blood work in our patients on LEN maintenance? How often do we need them to, we can't fix this, but for example, a lot of our patients have to still call the pharmacy for the lenalidomide every single month, deal with the logistics of it and so forth. And so it's a big deal. And I think it's one of the things that physicians, we never think about. We don't talk about it. We're not aware that it's happening, but it's happening. And so research there is ongoing. For financial toxicity, other groups have published similar data to us in the past that about 20-30% of patients do have financial toxicity. We were lucky to see that financial fragility, which is a different term meaning that having to declare bankruptcy or having to skip medications or food because of your myeloma, or not being able to handle even a $250 unanticipated medical bill. Those rates are pretty low. Less than 10% of patients reported that. But we did find that one of the biggest predictors of financial toxicity was the young age, which is a little surprising because I would argue that I think a lot of our resources in terms of making sure that our vulnerable patients are being cared for is focused on older adults, focused on, for example, geriatric assessments, focused on making sure they have caregivers. In reality, it's our younger patients who often have a livelihood of their own that's being disrupted by the myeloma, often have their own caregiver, their own dependent they're trying to take care of while also fighting cancer and doing a full-time job at the same time. They're the patients that probably have the most financial toxicity, and I think some of our interventions in the future we can tailor towards them.